All right. Well, good morning, everyone. I think we have a good crowd to get started, and there will be more people joining. Um, it is my pleasure to introduce a new speaker to us, although I'm actually trying to remember. He'll tell us when he joined faculty, because I know it's been over a year, but I think it's more than that. So he'll fill us in. But Dr. Chadwick Campbell is an assistant professor in the UCSD School of Public Health. He has an MPH with a concentration in health education and a PhD in medical sociology. He has more than 20 years of experience in community engagement and outreach, HIV prevention and testing, and social behavioral research. He employs qualitative methods to explore the influence of intersecting social and structural inequities on HIV vulnerability and the illness experiences of living with HIV, primarily among BIPOC, sexual, and gender minority populations. And he will tell us now how long he's been here and also head into his talk today. So, Chad, I'll keep an eye on the chat for you and probably only interrupt you for clarifications, and we'll save some time for chat at the end.
Okay, thank you, Jill. I started at UCSD exactly 2 years ago. It was August of 2022.
Well,
Um,
congrats on your 2 years.
thank you. Thank you all for having me. I'm excited to share this with you. This is actually an analysis I've just been working on, and I'm finishing up the manuscript. And so I'm happy to share this with you. Just a little bit more about my focus is I tend to think about or to focus my work on exploring social and structural barriers and facilitators of HIV care engagement, medication adherence. Just being a sociologist, I tend to think less about the individual level stuff and more about sort of the social community and structural. And so, this administrative burden piece that I'm going to talk to you about today is something that I've just recently started exploring, and I'm excited to talk a little bit about it. I need to advance the slide. Let's go. There we go. I have no conflicts to disclose today. And so, since I'm talking about structural intersectionality today, I always like to start with a little bit of an overview of intersectionality and structural intersectionality in particular. I know that it is a framework that is being used increasingly, but I know a lot of folks, it's still sort of new. So, I like to start with the beginning and talk a little bit about where intersectionality comes from. It's rooted in Black feminism, and it goes. This word intersectionality comes along in the 1989 by Kimberly Crenshaw, but these ideas have been around for a long time. Some of the earliest writings that people point to are, during the times of slavery, and so we have this speech by Sojourner Truth called "Ain't I a Woman," where she talks about how men say that women need to be helped into carriages and lifted over ditches and have the best places everywhere, but no one ever helps me into carriages or mud puddle or over mud puddles or gives me any best place. And so this is one of the earliest pieces that people point to say she's acknowledging that being a woman is different depending on your race, your class, and at that time, whether you were a slave or free. And so being a woman means something different depending on other parts of who you are. The Combahee River Collective in the 1970s was a group of Black queer women or queer women of color who talk about how class oppression and racial, sexual, and heterosexual oppression are all sort of interlocking. And so they saw as their task to sort of address all of those things at once. And then Audre Lorde talked about how we tend to identify one way in which we are different, and then assume that to be the primary cause of all oppression. And so here she's just talking about this idea of a single axis of oppression and how we tend to do our analyses based on race or sex or sexual orientation, as opposed to understanding that those things are all interconnected. So intersectionality is a theoretical framework for understanding how multiple social identities such as race, gender, sexual orientation, SES, and disability intersect at the micro level of individual experience. And I just want to pause there and say that's often where people stop. So you see a lot about people writing, people with intersecting identities. But really intersectionality is pointing us to structure. And so it continues to say that those individual experiences are reflecting interlocking systems of privilege and oppression at the macro social structural level. And so intersectionality is really telling us we need to think about those intersecting structural oppressions that are affecting people because of their multiple intersecting identities. And so it's not about addressing the individual level, it's about addressing the structures. It shifts us from thinking about people experiencing, this additive mode of saying people experience racism and classism and sexism to thinking about how sexism is affecting the experiences of racism and how classism affects the experiences of racism. And so we know that racism is not the same experience for men and women. And we know that sexism is not the same experience for Black women or Muslim women or white women or poor women, et cetera. And so this is essentially what intersectionality is telling us we need to do to think about how these things are interconnected and how they shape each other. Uh-oh. Oh, there we go. All right. So just to go over some of the tenets of intersectionality, social identities are not independent and unidimensional, but multiple and intersecting. People from multiple historically oppressed and marginalized groups become the center, the focal or starting point of the work. And as I was mentioning before, we can't stop at identities. We can't say people with intersectional identities or multiple intersecting identities, because at the end of the day, we all have multiple intersecting identities, right? And so whether you are a white heterosexual cisgender man with lots and lots of money, that is an intersectional, like those are intersecting identities. The same is true for people who are Black trans women living with HIV. And so we can't just stop at the intersecting identities because it's not about that. It's about the structural oppression that affects people because of those identities. So, last thing about this, Kimberly Crenshaw identified early on in her work three types of intersectionality. As I mentioned, I'm going to focus on structural, but I just wanted to mention the others. So, I'll start with the other two. Political intersectionality is about how competing political priorities can leave people out, can marginalize issues faced by some particular group. So, the example she gives is that she wanted to get domestic violence data from the Los Angeles County and by neighborhood. And there were groups opposed to the city releasing that data. So, on the side of the anti racist civil rights groups, they didn't want that data released because if it showed higher rates of domestic violence in communities of color, that it would shine a bad light on those communities. And on the other hand, feminists and people who were fighting against violence against women didn't want the data released because they feared that if it showed higher rates among communities of color, that it would give the powers that be more ability to sort of ignore the problem. And because these two factions both had their own reasons for not wanting the data released, what that meant is that women of color are left in these situations, and we can't see the data showing that. And so political intersectionality, that's what political intersectionality really speaks to. And you could, since I'm talking about Black sexual minority men, I could say we see the same thing in my own community, which is Black folks who are doing civil rights work might often leave out the issues facing LGBTQ plus folks in the community. And on the other hand, the gay rights movement has often not paid attention to race and the differences within the LGBTQ community by race and ethnicity and class and all of those things. Representational intersectionality is about how we construct women of color socially and how we can erase one form of domination for another based on how we describe things. So a great example that she offers is the Central Park Five. On one hand, people were describing this solely as an issue around race because of how these men were treated, these young men were treated. Others were framing it as explicitly violence against women and leaving out the racial component of that case. And so it's about how you represent a story, how you represent the issues that you're talking about that can negate the other type of oppression that may be involved or other types of oppression that may be involved. So structural intersectionality is about acknowledging how social location at the intersections of race, gender, class, immigration, et cetera, can make the lived experience is qualitatively different for people in these different groups compared to the dominant group. Um, and so when we think about structural issues, we're talking about policies and laws, things that are sort of shaping our lived experience, our lives on a daily basis. The example that she provides, and I like using her own examples because I think they really do a great job of illustrating this. She talks about the marriage fraud provision of the Immigration and Nationality Act, which was revised in 1990. Prior to that, people who moved to the United States to marry an American citizen or legal resident had to stay, quote, properly married for 2 years before they could apply for residency. And what that meant is that women who were married to American citizens and in a situation where they were experiencing intimate partner violence would stay in those marriages for fear of being deported if they left those marriages. And so there was this big gaping hole in the law that allowed that promoted women staying in these violent situations because they were required to in order for them to be able to stay in the country. And when it was revised in 1990, they created a waiver for it, and that's a great step forward. The problem is it required sorts of documentation and proof of this experience from police, from counselors, et cetera. And immigrant women often have less access to those things. And so structural intersectionality is about saying, in this particular case, immigrant women are in a place where they are more vulnerable to being stuck in these situations than, say, an American citizen or a white woman in this case versus Black women, and because of what I said earlier about trying to protect the community. And so that's what the structure is about. And so this has been written about in a few different ways. One I want to point to is the second bullet under the line, which is Black, gay, and bisexual men are made more vulnerable to HIV by housing, economic security, high levels of stigma and discrimination, and their intersections with homonegativity and racism. And so these things are sort of creating more vulnerability for some groups than others because of their social positions. And often people are in these situations where they're already experiencing poverty, stigma, other types of stigma before they're diagnosed with HIV and then trying to care for themselves. So, there are these 6 core themes, and I'm putting this in here because the data that I'm going to share with you really speaks to some of this. Social inequality, intersectionality points us directly at power relations as producing social inequality. So instead of looking for other explanations for racial economic inequities, we look directly at racism and sexism and classism as producing these. Relationality speaks to the fact that that one identity doesn't have any particular meaning or value without its relationship to others. So being gay or trans or bi is only has some value in society because of its relationship to heterosexuality and heteronormative heterosexual norms in our society. These are complex questions that require us to ask and to do complex analyses and ask complex questions of our participants, and to think about these things. So one of the question, well, I have several questions, but one of the data points that we often cite, and I've cited it, is that 1 in 2 Black, gay, and bisexual men will be diagnosed with HIV in their lifetime. And the questions that I'm always left with are which ones, what region of the country, what level of education, income, housing stability, incarceration history. The way that it's talked about is that it's just 1 in 2 Black gay men, period. But in reality, there are some things that we can see that make these things different across regions and across socioeconomic class, et cetera. In that same paper that had that finding in it back in 2016, they also acknowledged that the risk of being diagnosed with HIV is higher in states like Maryland, in Washington, D.C., in Florida, Georgia, Louisiana, Mississippi. These are, demographically speaking, the blackest states in the country, right? So without acknowledging that racial piece, we are missing something. My guess is that, I have no data for this, but my guess is that the risk of being diagnosed with HIV for Black sexual minority men in those states is probably much higher. But that's not included in that analysis. And so that's a piece of what is meant by we need to complicate these questions and not think about them too simply. And lastly, intersectionality really incorporates social context. So thinking about what else is happening in the community, what's happening with laws and policies that may be shaping these experiences, and with an eye towards social justice. So it's not just about acknowledging the oppressions, but it's about putting forth work that is about addressing them and trying to correct those. So I want to switch into administrative burden just to give an introduction to that. Administrative burden is something that I've been exploring recently because years ago, I can't remember how long ago it was, there was an article in the Atlantic magazine about, it was called the time tax. And it was about the extra work, the extra time that people who have few resources, who need government assistance, who need food stamps, who need public medical care, et cetera, all of the extra time it takes for them to do that. And so I started to think about this because in these narratives that I'm going to share with you right now, it started to jump out to me that what some of these men were describing as barriers to care were actually about how hard it is for them to get access to the care they need because they don't have private insurance, because they don't have easy access to the knowledge of how to apply for these programs and to get the help that they need. And so administrative burden is defined as an individual's experience of policy implementation as onerous. And yes, the person who wrote this, his name is actually Burden. Um, and so I just think that's funny. And then three types of administrative burden that have been identified are compliance costs, enduring tests, filling out forms, providing documentation. There's the learning cost. There's the need to learn about the program, the eligibility conditions, and other aspects that they need to know in order to be able to apply for these things. And then there's the psychological cost, the stigma associated with the program, the disempowerment, the way people feel they are treated. All of these things are burdens that are placed on people in poverty and people who need help in order to get the care that they need. And so we'll come back to that a bit later. Um, so now that I've laid the sort of theoretical stuff out, so the background is stuff that you all probably know really well. Black sexual minority men continue to bear a disproportionate burden of HIV in the United States. In the South is where we see the highest incidence and prevalence. And Black sexual minority men living with HIV in the South have less than optimal care engagement and viral suppression. And in Texas specifically, which is where this work was conducted, there's lower Black sexual minority men with HIV have lower ART adherence compared to white Hispanic men, and lower sustained HIV viral suppression than white sexual minority men. And we know that there are lots of barriers and facilitators to care at the individual and interpersonal levels. We know about stigma and mental health, substance use, intimate partner violence, social support. At the structural level, there's lots that's been written about access to care and all of what that means, insurance status, poverty, mobility, migration. Transportation is something that I'm starting to see a little bit more about as I'm reading through the literature. And there are other barriers built into systems that we have not explored as much. And so I'm hoping to contribute to that. So these men were a part of a larger longitudinal cohort study. They were originally recruited when they were 18 to 29 years old between September 2015 and November 2016. Susan Kagelis at UCSF was the PI of the original study. Eric Storholm at SDSU wrote an R21 to do an additional wave of data collection. So they have completed 4 surveys over about 5.5, 6 years. And then we recruited from the 4th wave with a specific interest in doing qualitative interviews with men who reported less than optimal care engagement. So we did that by looking at their surveys and looking for men who reported missing ART doses in the past 12 months, who reported a detectable or unknown viral load, or who reported that they were not currently taking ART. And so I did these interviews from July 2022 to September 2023. We conducted interviews with 27 men in the Houston and Dallas metropolitan areas. and which is where they were originally recruited when they enrolled in Susan's first study. So we did semi-structured interviews that lasted about an hour, and those interviews focused on syndemic conditions like substance use, IPV, stigma, care engagement, barriers of facilitators of care, art adherence, and COVID-19. And we were doing this during the pandemic, so we really wanted to try to understand how COVID was affecting their care as well. These were audio recorded, transcribed verbatim, and we analyzed them using thematic analysis. So on average, these men were around 30 years old. Most had either high school or GED or some college. Only about 22% had a college or graduate degree. They all identified as gay or bisexual. One non-binary, one transgender, and the rest identified as man. You will notice that when you look at employment, that the majority of them, around 56% of them, were either employed part-time or unemployed. The majority of them, a large majority, I think, almost 60% of them, made less than $40,000 a year, and about a quarter of them had no insurance at all. And so this sort of lays the this economic this economic data sort of lays the groundwork for how the transportation and administrative burden affected them. And I'll say more about that as well in a second. Okay, so one of the things that came up a lot in these interviews was about location of services and transportation. And there's some newer data that I just uncovered in the last couple of days that was conducted in Texas, where they found that counties that had the highest incidence and prevalence also had the highest proportion of residents of color, and they had to travel much further to get to the care, which was centralized in the center of big urban cities, right? And I'll just say that while I did this work in Texas, I also have been working on a project in San Diego where I have heard the exact same thing. So this is something that is across regions and cities, et cetera. So HIV care services tended to be located far from where participants lived, and this was in part because they couldn't afford to live in the center of town. They couldn't afford to live close to where services were offered. And Houston and Dallas, I don't know if any of you have spent any time there, but these are very large cities with lots of traffic. And public transportation is limited. The extent that people have access to it, they described it as really frustrating and hard to navigate. And this is a burden that is placed on people who don't have the resources to live near the services, don't own cars, et cetera. So Darius described how COVID restrictions affected his transportation options and how limitations on public transit overlapped with COVID-related clinic challenges. And so he says COVID made it a struggle because the bus only allowed certain amount of people on. And when you're standing on the train, everybody don't want to stand there. You're 6 feet apart, so you have to wait until the next two trains come to get there. And then about the time you get to the place, they change. You can't go in there. You have to make an appointment. The appointment is 2 weeks away. And so he goes on to talk about how during COVID, the clinic would change policies around, how many people could be in, whether you need an appointment or you could drop in, et cetera. And he would often not find these things out until he had already made that journey on public transportation to get to the clinic. And when I asked Jamar about what he thought would improve his engagement in HIV care, he said, I feel like if there were more clinics available that were not just in the centralized metropolitan Houston area, because most of the clinics, I have to drive out an hour to get there because of traffic. So if there were more clinics in my area, that would be helpful for my medication and everything. And so what both of them are talking about is just being really far away from services and how that sort of creates a barrier for them getting care. And one more quote I'll share on this. Philip talked a lot about multiple health issues that he was dealing with, including extreme fatigue, which at the time of his interview remained unexplained by his doctors. And so he described what it's like to remember taking his medications on days when he has to see his doctor. And he said, I know my medication is important to take. And then sometimes when I get up, I'm rushing, I forget, and then, I'll be on the bus line. So when I do have to go to a doctor's appointment, I have to leave 2.5, 3 hours earlier because I live way on the other side of town. So I have to catch the bus into town. And then by the time I get into town, I'm like, shit, I forgot. Then by the time I go to the appointments, do what I need to do, and I get back home, it's like, oh, I'm free to go to sleep. Just like, damn, you forgot to take your medicine. And so for him, he talked a lot about how stressful it is for him dealing with his health issues, dealing with this extreme fatigue, and having to rally himself to get far away from home to get to see his doctor, and that contributing to him being so tired and forgetting to take his medications. Um, uh-oh, it doesn't want to advance. All right. So thinking about administrative burden, let me check the time. Okay. Administrative burden and accessing public health care. So up, this is a typo. So these are the bullets from the slide before. My apologies for that. So the men talked about, as I mentioned earlier, they talked a lot about the challenges of of having to apply for different services, having to renew their health insurance, et cetera. And so this was something that made me really think about this administrative burden piece. So Gerald is talking about when he was first diagnosed at a young age. And he says, I think I was about 20, maybe 18 or maybe 20, I can't remember. But I ended up going to the health department to try to get some type of treatment because I did want to live. So I went to the health department. I think they did a blood test, whatever. They figured out I was positive. They put me on medication. They gave me 3 months worth of medication. I couldn't continue it because I think they just didn't have the resources and they wanted me to get on Social Security. And I just wasn't prepared or didn't even have the knowledge and know how to do all of that. And so he is, at a very young age, ill-equipped to sort of navigate the public benefit system and felt that he was on his own. And so he ended up going without his medications for quite some time before he ended up getting back on treatment. Um, Simply because he didn't even know where to start to get Social Security. And then Craig shared that, during the pandemic, he was trying to get his medications and in some public benefits, I forget exactly what Craig had at the time, he had to periodically renew his benefits. And so during COVID, that became a challenge because of COVID restrictions and the clinic not allowing certain amount of people in, et cetera. So he says they wouldn't even let me go in the building and sit down and have a meeting. They weren't doing Zoom calls. It was at least going on a month. I don't know if it was a month exactly, but it took that long. I was out of medication. That's what I had to renew when I tried to put in a prescription. They told me my insurance was out, so I had to renew it. And that was what the whole situation was. And so I asked him how long he went without his medications. He said about 2.5 weeks. And so for him, it was just about this extra step of renewing his insurance. And during COVID, that became really hard for him. And I'll just say that in addition to this, Craig is also someone who didn't have a car and also talked about transportation. And so, linking it back to transportation, if he is, unable to go and get what he needs, and if he does get an appointment, he does have to make that journey to get to the place where he can renew his medication. So these things sort of overlapped with each other. Um, and then lastly, Chris says, I had gone through a local healthcare system. Their system, I did not like it at all. I felt like a cow standing in line with other cows, being ready to get cut up. But the only thing is, it takes a million years for you to get cut up because it just takes that long to see a doctor. I just didn't have a good experience with it. The visits and the referrals would be so far out. So I had to learn it. I just didn't like the system. It was not streamlined, and you have to go there, and there was a lot of other people there. I just wasn't used to all that. And so this speaks to that psychological cost that I talked about and the challenge of having to endure these extra long processes. He describes feeling like a cow, so that sort of dehumanizing aspect of what it means for people to have to access those services. Oh, got it. Okay. Um, Here we go. So structural intersectionality really does determine vulnerability to other barriers. So remember, I talked about, one of the core themes of intersectionality being about social context. And so I wanted to take some time to think about both the participants in this study, but also what is the broader structural context that is shaping these experiences. And so Black sexual minority men living with HIV are occupying a structural position that subjects them to multiple intersecting forms of institutional and structural oppression. And so, as I mentioned earlier, most of these men were employed part-time or unemployed. Less than a quarter of them had a bachelor's degree or higher. Most of them were making less than $40,000 a year. A quarter had no insurance. As a result, they were specifically more in need of they needed to access public health services and confront the associated administrative burden, and many had to use public transportation or live far away from the center of the city because of their financial resources. And then when we take a step out of this particular sample of men and we think about what is the broader structural context in the state of Texas and in these cities, in Texas, we see that the uninsured rate for Black people is around 15% compared to 9.7% for whites. Black poverty rate is 20% compared to 8.7 for white residents. 18% of Black people live in high poverty neighborhoods compared to only 4.5% roughly for white residents. Texas has not adopted Medicaid expansion. And so in the South, with the exceptions of, I believe, Louisiana, Arkansas, and Oklahoma, all of the Southern states still have not accepted Medicaid expansion. So Texas, Louisiana, Mississippi, Georgia, Florida, Alabama have not expanded Medicaid access. So that creates another barrier. Segregation is a major driver of disparities, both in healthcare access and health outcomes, and also the use of public transportation. And so out of 221 metropolitan areas, Houston and Dallas were number 16 and 18. I'm sorry, Dallas and Houston were 16 and 18th most segregated, respectively. And Texas ranks above the average of all states when we look at segregation and education disparities between Black and white residents. When we think about things like heterosexism and HIV stigma, we see that Texas is categorized by the Human Rights Coalition as a high priority to achieve basic equality, which is their lowest category when they look at statewide policies that affect LGBTQ people. And then there's no protection from discrimination in housing, education, or public accommodations. There is no requirement of sex education in the state of Texas. Schools that offer it have to talk about abstinence first. They also have to include that homosexuality is not an acceptable lifestyle choice, and that it is a criminal act in the Texas Penal Code. And of course, you all know that states cannot enforce sodomy laws, but some states, so the case that got sodomy laws thrown out comes from Texas. So I wonder if there's a little bit of just resistance there to keep that law on the books, even though they can't enforce it. In my home state of Louisiana, state legislator brought up a bill to remove their sodomy laws from the books just in the last 5 years. And the legislature voted to keep those laws on the books. So this is the context in which queer people are living in the South. Among Black sexual minority men, the intersections of racism and heterosexism are associated with anxiety and heavy drinking, which of course we know are associated with higher risk of HIV acquisition and also poor clinical outcomes. Only about 35% of Texas secondary schools provide information about HIV that is relevant to non-heterosexual relationships. And then there's HIV. Then the use of criminal laws to prosecute people living with HIV under statutes for aggravated assault, attempted murder. The state courts have consistently found that the bodily fluids of people with HIV can be considered a deadly weapon. This is important because we know HIV criminal laws perpetuate stigma. There's data showing a positive indirect association with psychological distress. Studies have found that HIV criminal laws and criminal prosecutions lead to distrust of medical providers and concerns about their data being shared with law enforcement, and people who live in areas where HIV exposure or transmission is a crime have shown a lower level of adherence to antiretroviral treatment. So all of these things are really important to give context to the experiences and sort of these barriers that folks are facing when they're trying to take care of themselves. So importantly, in this analysis, there is nothing that is focused at the individual level. This is to say that these intersecting structural oppressions are a driver of HIV disparities and that addressing any one of them would be insufficient. So what I've laid out so far is just that segregation and economic inequality, along with a lack of LGBTQ protections and sex ed policies and HIV criminal prosecutions, are all sort of working together to create a context and an environment that makes some communities, and in this case, Black sexual minority men, first more vulnerable to HIV. They are also more likely to have to depend on public transportation, more likely to deal with the administrative burden. And as Lisa Voleg pointed out when she wrote, we are not all in this together. COVID-19 is affecting communities of color, poor people, very differently than it is affecting many other folks. And all of this sort of contributes to suboptimal care engagement and worse clinical outcomes. So new strategies are really needed to increase geographic access to HIV primary care, maybe using alternative care sites, transportation interventions. I'm currently working with a couple of colleagues to write up a grant to develop and test a transportation intervention to see if we provide transportation to people that they can use for whatever they need it for, if that will increase their overall quality of life and their engagement in care and medication adherence. My grand idea is that administrative burden needs to be lessened in order to make care more accessible, so we can find a way to remove the barriers that disadvantage only those who have fewer financial resources. In the meantime, alternatively, some of these ideas are not these. This is not a new idea, but peer navigation and others, case managers, et cetera, can be a really great resource to help people to overcome those barriers to getting the services that they need. And the psychological impacts of administrative burden can be a deterrence. And so I think it would be really great if we could figure out a way in future policy work to eliminate or reduce the differential experience of people with means and people without. I was thinking about this and thinking about how, as someone working at UCSD with really great insurance, I never have to worry about filling out that paperwork to get public benefits. I never have to worry about being told that I am, quote, no longer eligible for the thing I was just told I was eligible for 6 months ago, which happened to more than one of the participants in this study. And so there is this real difference between how I access care and how they access care. And I think there needs to be some work done to try to figure out how we can reduce those differences. And then without addressing these intersecting structural challenges, we can't expect everyone to be able to successfully manage their HIV care and treatment. And this is just a shameless plug for some of our other work. We have two other papers out from this same study. One is about the influence of engaged and supportive providers, and the other is about interest, awareness, and questions that people had about long-acting injectable ART. And then we have one under review that is about COVID-19 and the syndemics of IPV, mental health and substance use, on care engagement. And I will stop there and leave the last, it looks like we have about 19 minutes for talking, for questions.
Thank you so much, Chad. This was really thought-provoking, and I think probably, I mean, lends itself both to the research sphere and the clinical sphere. I know you and I have talked a lot about transportation, and I was curious, and actually, let me open it up to others first. I'll save my question. Let's see what others have, because I see Daniel has shown his video. I have a feeling the high rounds committee has lots of questions. Go ahead, Daniel.
Thanks. I do have a question. Thanks, Chad, for an excellent talk and overview. I guess my question was in regards to, the fact this study was done during COVID. Were you able to look at whether or not like telehealth, whether video or telephone helped with access for these folks, or were most of the clinics you were studying only seeing people in person?
There was a mix. So there were guys in our study who had private insurance, and those guys tended to have more access to telehealth during COVID. So the guys who had jobs with private insurance were able to see their doctors online. And then some clinics were only seeing people in person. And so there was, the standards the things we all went through, like temperature checks and checking
Yeah.
symptoms and wearing a mask to be able to go in. And for them, the real challenge was the limited availability of appointments. And so sometimes those appointments were far out because they wouldn't allow as many people to be in the clinic at one particular time. So yeah, it was a mix. And so the ones who were able to see their doctors online um, were able to just do their blood work, talk to their doctors over Zoom, pick up their prescriptions. Interestingly, though, a lot of them did not want to see their doctors virtually. They wanted to go in person, even during COVID. And so some of them missed the virtual appointments because they just didn't want to do it. So there was a real mixture there when it comes to that piece.
Oh, well, interesting.
Go ahead, Tim.
Really interesting. It just struck me that a lot of the research that we do related to HIV historically has all been in urban centers, and we really haven't engaged people more broadly in rural areas in our HIV research agenda. I think there are a lot of interesting tools that we have available to us regarding telehealth or pharmacy-based research. There's or pharmacy-based care. There's pretty much every national pharmacy chain is kind of clamoring to kind of get into providing some healthcare, and I just wonder if there could be work on how we implement long-acting ART in these kind of decentralized settings.
Mm.
And I know for the ACTG, that's a big part of our agenda to to really investigate how we kind of maximize long-acting ART to achieve our end the HIV epidemic goals.
Yeah, I most of the guys did live in Houston and Dallas. There were maybe two or three that actually no longer were living in Houston or Dallas because they lost their employment during COVID or et cetera, and they went back to their hometowns. And so I did get just a couple of anecdotes about living in a rural area. One guy in particular told me that there was one clinic where you could get HIV primary care, but that clinic was serving multiple counties. And so there was one doctor that everybody who wanted HIV primary care was trying to see. And he really liked her, but it was really hard to get an appointment. And the Houston and Dallas were hours away. And so he had been without care for a while just because he was exhausted trying to get access to his provider in this rural area. So I think, yeah, if we can find ways to provide that, through pharmacies or other ways, I think that would be really important to increasing access. I don't know if I answered your question, but
No, yes, and also a very status neutral approach because the same concepts and um, strategies would apply for providing long-acting PrEP as well.
hmm hmm
Dave Gerlotti, please.
Hi, great talk. And honestly, yes, like I was just sitting here like, oh my gosh, so true. One just comment about Texas. I'm on the California ADAP Medical Advisory Committee. And when we were kind of evaluating bringing on new medications to the formulary, we often do a cross-state comparison, and Texas is often one of the comparators. And I have not yet seen Texas adopt a medication on their formulary that isn't specifically an HIV medication. And I presume it is because without Medicaid expansion, they have to pay for all the HIV medications, which are very expensive, which leaves them very little opportunity to do other things for people with HIV in the state. So it is interesting, like even at that kind of macro level, how things can just continue to compile to create disparities. My question though is, have you looked at people who are successfully able to navigate all these different hurdles and remain in care? And what kind of factors or resiliences or experiences or programs or whatever seem to be relevant for, kind of their stories? I'm not sure if that's like a good question, but I just like, I wonder, sometimes there are some people who can do it, and are we just not taking a look at them enough to see if there's something we can learn from them and apply to other folks?
Yeah, so two things. In the paper that I published about long-acting injectables, one of the guys most of them were very excited about the possibility, but most have been told that they were not eligible and would not be eligible to get it for quite some time because Texas has not approved that for people on public benefits, to your point. The other piece, most of these guys were managing to navigate the system. They had these hiccups along the way, so they were staying committed to navigating the system and getting the services they need and renewing their prescriptions and all of those and their insurance and all of that. They had these hiccups along the way, like the one example that I gave you, where he's told you need to renew your insurance, and he ends up going a few weeks without his medication. There was a man who who was unhoused, and before the pandemic, he would go and pick up his prescription. And during the pandemic, they wanted to mail it to him, but he had no address. And so he went for quite a while without his medication because he had no address. He ended up checking into a homeless shelter where they were able to mail his prescriptions to the shelter. And so he was committed to staying on his medication and trying to figure out how to navigate it. I don't know if there are any particular qualities or types of resilience other than people said, I want to live. And so they were just willing to keep dealing with this stuff. And I think what makes me sad about it is the idea that they are having to do that much work in order to just get the help that they need. And so there may be something in there to your question in the data that I just haven't really explored. But I do know that most of these guys were figuring it out, even though they had challenges along the way. The number of people in this small sample of 27 people who had at some point been without their medication was kind of staggering. And it was, a month here, a year there. Maybe I lost my insurance. Maybe I had to move out of town and didn't know how to start. One guy who was from a small rural area moved into Dallas and was overwhelmed by the massive city, the systems, trying to figure out how to navigate them, feeling like just a number and a pile of other numbers. And so there are lots of times where they were out of care or without medication for one reason or another, but they kept at it. Or they went back to it. And so I think it was just the desire to live and be healthy that was really driving them. But I will take your question and go back and look because I'm curious about that too.
Anik, before we get to Aaron popped something in the chat, so I just want to get to that. I'll read this to everyone. Have you found any data about healthcare provider bias as a barrier? I see patients for PrEP who were denied services by their PCP. And that's the first question. And then the second one is sometimes the small town culture can be a barrier. You don't want to run into your aunt or classmate or someone from your church at the HIV clinic in town, and people prefer the anonymity of getting care in another city or I guess across town or somewhere else.
Yeah. excuse me, I didn't see healthcare provider bias as a barrier. I did hear people talk about um, not feeling valued, sort of just as the guy talked about and what I just shared about feeling like a cow waiting in line to be slaughtered, to be cut up. Um, I heard stories like that, that providers who they didn't feel were very supportive of them, providers that made them feel dismissed. And so it wasn't so much about provider bias in the sense that they wouldn't provide them the services like PrEP that they wanted or needed. It was more about this system, this public healthcare system, where people just felt like a number and didn't feel valued or paid attention to. And so that was really the main barrier that I saw as it relates to providers. And as I mentioned, most of these guys lived in Houston and Dallas. And so I didn't hear a whole lot about the small town culture since they were in these big cities. But I can tell you just in my other work in Baton Rouge, Louisiana, which is my hometown, there is a cluster of HIV related services and clinics on this one street. It's called North Boulevard. And people would tell me in interviews that they don't want to be seen on North Boulevard because they don't want people to know that they're in the area that's quote for HIV people. And so, yeah, that's 100% a factor. The guy that I was talking about a few minutes ago who moved to Dallas and felt lost in the system, the reason he moved to Dallas is because he was beaten pretty severely in his small rural town because he was gay and someone had accused him of um, grabbing the crotch of someone at work or something like that. And so he told me that getting care for HIV in that small town was really scary for him, but it wasn't so scary because now he lived in Dallas. And so yeah, that's definitely a thing. But people were not really able to travel too far because Texas is so big and these cities are so big. And because of the transportation challenges, going really far to get care was really not an option for most of them.
Great, very helpful answer. Anik.
Thank you. Thank you, Chad. This was so interesting. And thank you for going through the theory before getting into the data. I think that's always a nice thing. I was thinking you should actually present this on the T32 seminars. That'd be really helpful for people who don't know about intersectionality. So I had one question, but then David made me think of another question. So I'm going to start with that one. Did you get any data on how having HIV and having to deal with it affected their job situation in terms of if you have to take half a day to get your new set of pills or whatever, does it affect their job opportunities or at least the number of hours that they're working and basically job opportunities and earnings. And the other question I had was, I was surprised that you said that the next grant that you're writing or the grant that you're currently writing is on transportation, given that even if it's free transportation, it's still going to take them 2 hours to get there and to come back, etc. And so I was curious why you had chosen to focus on transportation rather than, as Dan mentioned, telehealth or having a physician at pharmacies once a week, at local pharmacies once a week doing the consultations there, or other interventions that mean that we're bringing access to care closer to them rather than them having to move around.
Yeah. So to your first point, I would say that what Min described actually worked in the other direction, which is to say that they would miss going to the doctor because they had to go to work. So it wasn't that men would miss time from work to go to their doctor's appointment. They would tell me, it took me a long time to get to the doctor because I couldn't spend that much time going to the doctor and miss that much work. Right. And so it was actually taking more of a toll on their health than their work. So the other thing, just to add to this administrative burden piece, is in the city of Dallas, I heard several times that there were these long intake processes. And I eventually just asked someone to sort of like lay it out for me. And what they told me is that at one particular clinic, you have to go in early in the morning, 7:30, 8 o'clock in the morning, and you are there for hours and hours and hours. You are seeing a doctor, someone to help you with benefits, someone to help you. You can see a foot doctor, you can see a psychologist, a case manager, and you're there all day or most of the day. And that is a real barrier for people because, again, missing work or school or whatever else you have going on to spend hours and hours at the doctor's office, not to mention the travel time it takes to get there, was a real barrier for people. So it really didn't seem to work in the direction of interfering with work. It really interfered with healthcare. And then your second question, I forgot it. Tell me, just give me a
Why,
hint.
why had you decided to focus on?
Transportation. Yeah, so it comes from the fact that I've heard this narrative about transportation in multiple cities. So I've been working with Susan Little, who was here. I don't know if she's still here, but I've been working with Susan on a project in Miami. And we heard this a lot in Miami. I've heard this in Houston and Dallas, and also in San Diego about people struggling. Oh, there's Susan. Hi, Susan. People struggling to get to care. And mostly it's the guys who are reliant on public transportation. So it's not so much, yes, the driving really far is a problem, but the 2 to 3 hours of travel time is because of the buses. That's not being in a car, right? So if we are able to reduce that 2 to 3 hours to 45 minutes, does that help people? The other piece of it is we're wondering, what if we give people access to transportation for things other than their doctor's appointment? What if they can use it to go to work or to visit a friend or to go pick up their medications or grocery shopping? Does that improve their overall quality of life and improve their ability to stay on top of their care? So that's where the idea for the transportation comes from. Is just sort of just reduce that time that it is taking for them.
Yeah, no, that makes sense. So basically, you would be giving them like a free Lyft or Uber.
Yeah.
membership.
Well, that's what I wanted to talk about in the last minute that we have. Sorry, Dave. Is your transportation grant, because I think there are several things to consider when you're talking about transportation, and it depends on what patients actually have access to. So you can't get a Lyft or an Uber ride if you don't have a working phone. So if you don't have a phone, then you're either using a car if you have a car, and then you'd want to give people money for gas, which can be very difficult to figure out, like what that estimate is per month. And if they don't have a car, then you want to do a bus pass, but bus passes obviously, and I just saw a patient yesterday in the hospital whose wife told me she took 3 buses to get to, the hospital to visit her husband. And I would imagine in Texas and other places it could be even more difficult. But I think we always have to be careful about the ride shares because they do not work if you don't have a working phone or a reliable phone.
Mhm.
What's that?
You can give them a phone.
But then you have to pay for the phone and you have to pay for that. And I'm just saying,
Mhm.
Chad, I hope when you're doing this, you take into consideration the different circumstances that someone might have, depending on who they are. Also, we know phones get lost very easily. And so you have to factor in, do we need to give someone a new phone? I think it's also great that you're saying this doesn't have to be study related. This is transportation in general, which sort of speaks a little bit to universal basic income, like those principles.
Yeah,
It's
yeah.
obviously just a segment of what people need, but I think that's really exciting that you're considering that. It had come up recently with patients who come in different stripes and have access to different things, and the ride share is the easiest, but ride shares don't work if you can't reach someone. So, yeah.
Yeah, and I'm working on this with Eric Storholm and Will Vincent, who's at Temple, and so we're still trying to figure out what it might look like. We
Yeah.
don't know yet. And Susan, I just want to acknowledge something Susan just said about how there are transportation deserts. One of the things I didn't share was one of the participants talked about a bus that runs in his neighborhood, but it runs like morning and afternoon. In the middle of the day, there is no bus near his house, right? And so those are the kinds of things that they are facing when it comes to getting to where they need to get to. Um, I know we're over time, but I know there was one more question. I can
Sorry,
have time if you
he's
have
gonna have to
time.
send it to you after because we really
Okay.
actually try to end this 5 minutes till, and we didn't do that to give people time to get to their next meetings. Dave, I hope you'll connect with Chad after. Chad, this obviously was so thought-provoking. When you finished at 8:41, I was like, well, I hope we're going to be able to stretch the discussion. Obviously, not an issue at all. And we're definitely going to have you come back and talk about some of your other really incredible work. So thank you so much.
Thank you for having me. This was fun.
Of course. And thanks everyone for the very thought-provoking conversation. I think I used that word twice today. So anyway, have a good rest of the day and a solid weekend to all.
Okay.
Bye.
Bye.